Hello, I'd like to welcome everyone here today for our webinar entitled Deep Brain Stimulation for Movement Disorders. My name is Dr. William Ondo. I'm a professor of neurology at the University of Texas Health Science Center. I'm a specialist in movement disorders.
And I'm Al Fenoy. I'm an assistant professor in neurosurgery at the University of Texas in Houston as well, and I'm a specialist in deep brain stimulation.
Okay, so we were going to do this in two parts. I was initially going to start with just a very brief background of some of the diseases that DBS can be used for, concentrating predominantly on Parkinson's, essential tremor, and just a little bit of dystonia. And then Dr. Fenoy was going to actually discuss the surgical process in much more detail. So the first slide is really a list of published and known uses for deep brain stimulation in neurological diseases. Parkinson's disease is what this is most known for, and we'll spend most of the time discussing Parkinson's disease. But it's also been used for the last 15, 16 years for essential tremor, which we'll talk about a little bit. More recently, it's been advocated for dystonia, which is involuntary muscle spasms. And those are really the main movement disorders for which this has utility. There are a number of other conditions for which it's used. Obsessive compulsive disorder is a psychiatric disorder where patients just have to do things a certain way and can be very disabling, and it actually is FDA approved or officially approved for use in obsessive compulsive disorder. The other uses listed here: dementia, Tourette syndrome, seizures, depression. These have to be considered much more experimental at this point for deep brain stimulation. So we're going to talk essentially about the first three: Parkinson's, essential tremor, and dystonia. So Parkinson's disease, I'm going to emphasize on who is a candidate for these among these three different conditions: Parkinson's disease, essential tremor, and dystonia, because only some aspects of these conditions improve and some aspects unfortunately do not improve with the deep brain stimulation. So Parkinson's disease is largely defined by just examination features. There's 3 or 4 things we look for when we examine a patient with Parkinson's. The first, most characteristic thing is a slowness and smallness of movement. And anyone that's been to a physician with Parkinson's, they have the tap your fingers, tap your heels, that sort of thing. The second main feature is a stiffness of muscle, which is something that sometimes patients feel, but something we feel in the examination room where we bend your arms or legs and looking for this characteristic pattern of muscle stiffness. The next characteristic feature is tremor. This is typically a tremor when the hands are relaxed. For example, when patients are walking and they're just swinging their arms, you'll have a tremor, and it typically actually improves when you go to do something volitionally with the hands. And then another major feature is instability. So if you get pushed or pulled, your feet aren't quite quick enough to catch themselves and you're more likely to fall. Now, one of the complicating features of Parkinson's disease with typical treatment with dopaminergic medicines, the levodopa or the standard medicines that people take, is dyskinesia. And this is in fact the opposite of the other features. Whereas you have slowness of movement as far as the Parkinson's, when you take the medications for some time, you start to get too much movement, these wiggly sort of movements. An example would be if people have seen Michael J. Fox on TV, he tends to have a little bit of dyskinesia and he's wiggling around. And that's a long-term complication of treatment, medical treatment of Parkinson's disease. And these are the core features of Parkinson's disease that make the definition, and these are the things that actually improve quite nicely with deep brain stimulation. So patients that have prominent what we call motor symptoms, slowness, stiffness, tremor, wiggly movements, these are the things that pretty consistently improve with surgery. Now, for the next couple of minutes, I'm going to, I don't want to sound negative, but I'm going to talk about the things that tend not to as consistently respond to surgery. Because when we pick a patient for deep brain stimulation for Parkinson's disease, we're trying to weigh the things that respond very nicely versus the things that don't respond as nicely to come up with an overall conclusion about how much the quality of life will improve with the surgery. Okay, so there's a number of non-motor features, and these inconsistently respond. They're sometimes broken down in different categories. People with Parkinson's have a number of sleep problems. There's psychiatric, cognitive problems. Autonomic problems are things like blood pressure, constipation, bladder function, and then there's sensory things like vision changes, change in sense of smell, pain. These are other features that are common symptoms in Parkinson's disease. So sleep disturbance is very, very common, and sleep problems actually often predate the movement problems in Parkinson's by up to 10 years or so. So the process actually starts with sleep problems, and later people develop stiffness, slowness, tremor. So there are a number of things that may or may not improve with surgery. Excessive daytime sleepiness is probably the most common issue. This is often a side effect of medications, and surgery can, in many cases, can result in a reduction in medication, so it very well may improve the excessive daytime sleepiness. Crummy nocturnal sleep, so just bad sleep at night with frequent awakenings, this inconsistently improves with deep brain stimulation. REM behavior disorder is an interesting phenomenon where you act out dreams, and this is one of those things that happens years before tremor, stiffness, rigidity. This typically does not improve with deep brain stimulation. Involuntary leg movements while asleep and restless legs, which is kind of an urge to move the legs, these typically don't improve that much. And then sleep apnea is a moderate problem in Parkinson's. This is a very common problem in the general population where you snore and you hold your breath for 10 seconds or so. That's fairly common in Parkinson's, and that's not something that typically is going to improve with brain surgery. Some of the sort of psychiatric cognitive problems in Parkinson's can be very, very difficult to manage. We really have inadequate treatments for almost all of these problems, and these typically occur later in the disease, and become more of a problem. But as you can see by the list on the slides here, there's some overlap: depression, apathy, fatigue. These things, tend to go hand in hand with just a sort of a loss of motivation to do things. And that's a very common problem in Parkinson's. Visual hallucinations are very common, and these are typically worsened by medications. So again, reducing medicines with surgery often improves the visual hallucinations, seeing things. A very, very common problem. Up to about 60% of patients with Parkinson's will have these visual hallucinations, so it doesn't mean you're going crazy if you have these. It's really the norm to get this. Anxiety is an interesting one because some anxiety in Parkinson's is actually caused by the medicine wearing off. And surgery can smooth that out to some extent by smoothing out the sort of on and off response to the medications. But generalized anxiety typically doesn't improve. And then the last one, which is a big one, dementia. This is again typically a later feature of Parkinson's disease, and we're not very good at treating this. And unfortunately, surgery doesn't seem to help this very much either. So if overall dementia is the major feature of the biggest problem at this point, unfortunately, surgery is probably not going to help that at all. A few other briefly, constipation. I mentioned things like autonomic constipation, bladder problems. Drooling is a common problem simply because we don't swallow the saliva. These sorts of things typically don't improve that much with surgery, although drooling can improve a little bit by the improved motor function. And then the last sort of category of this, these sensory phenomena. Double vision, for example, is a fairly common problem. Loss of sense of smell is almost universal in Parkinson's disease. It's seldom a complaint. People don't notice it that much. But it does sometimes manifest as food tasting difference, because if we don't smell things, then your sensitive taste is also affected. Imagine, eating when you had a bad cold. It just doesn't taste as good. So that's what people actually notice. So these variety of things in pain, numbness, tingling, you can get these symptoms. As a rule of thumb, these tend not to improve with surgery. Okay, so with that list of who does, what does improve and what doesn't improve, who's a good candidate? Well, the main feature is that the movement problems, the tremor, the rigidity, the stiffness, that has to be the biggest problem for the patient. Okay. As a rule of thumb, with most of the type of brain surgeries, the response mimics that of levodopa. So everyone with Parkinson's disease that's considering brain surgery is going to be on levodopa or Cinemet or Stalevo. There's different preparations of this. But as a rule of thumb, and it's not perfect, but as a pretty good rule of thumb, if levodopa improves it, the surgery improves it. The advantage to the surgery is it improves it without causing those dyskinesia or those wiggly movements we talked about. So we look for people that have a dramatic change with levodopa, although again that change may still cause problems, but there has to be a big change with the levodopa. If, as a rule of thumb, again, if it doesn't improve at all with levodopa, it doesn't improve that much with surgery. A big caveat here is there are certainly many patients that don't take an adequate dose of levodopa to determine whether they really gets improved because of side effects or some other limitations. So typically when we see someone and we're considering surgery, we will give at least one time even a bigger dose of levodopa than normal to see the maximum effect of that, to see if it really gets better. Another thing is, as a rule of thumb, is younger age. The people that tend to do the dramatic benefit for this typically are in their 40s. Now, there's no age cutoff for this, so there's no number set in stone that's too young, too old, etc. But as a rule of thumb, patients that are younger, who also tend to be more dramatically responsive to levodopa, are the ones that do best. And then, as I mentioned, the patients that don't have very prominent non-motor features. So again, if someone was severely demented, and that was really the thing that affects their quality of life more than anything else, we wouldn't expect that to improve with deep brain stimulation. So that person really wouldn't be a good candidate for the procedure. Again, I want to emphasize, not any one of these rules is set in stone. There's as you can hear, there's a number of things we take into account, and you have to look at really the whole patient at the end of the day to determine whether you think they would benefit from DBS. Okay, so more briefly, we'll talk about these other conditions, just a couple of slides on this. ET is essential tremor. Essential tremor is very common, and this is a sort of tremor that happens when you use your arm. So you go to write and you shake, or you go to pick up a cup of coffee and the hand shakes. So this tends to be the opposite of Parkinson's, where the tremor is worse when you're not using the hands. There are exceptions to this, but as a rule of thumb, they're somewhat opposite in the way that they look. Now, with essential tremor, when it's mild, usually we can adequately treat this with medications, but when tremor becomes fairly large, such as 3 or 4 inches in its size, the medicines are seldom satisfactory. And in this case, really deep brain stimulation is the only really good option for patients with marked or severe essential tremor. There are some things that can still predict who does relatively better, relatively worse. The people that respond best with the tremor are those that have the tremor around in the hands and the wrists, so what we call distal tremor. In contrast to people that have more tremor around their shoulders or more towards the middle of the body, those patients tend not to do as well. There's exceptions, but as a rule of thumb, the distal tremor at the ends of the hands, feet do the best. And usually people with essential tremor have this distal tremor in the hands or the wrist. That's where the main tremor is. So as a rule of thumb, people with typical essential tremor actually do extremely well from that standpoint. The faster the tremor, the better. Now, this tends to go hand in hand with the area of the tremor, because tremors that do tend to be, say, around the shoulders are slower, and tremors around the wrists and fingers are faster. So that kind of goes along with that first issue of distal versus proximal. So distal, faster tremors seem to do the best. And in contrast to Parkinson's disease, age doesn't really seem to matter that much with essential tremor. Personally, I think the oldest person we've operated on is 94, a good healthy 94. They did fine. It would be pretty unusual to operate someone in the 80s with Parkinson's disease, but with essential tremor, it actually does go in a different location, and age really doesn't seem to mitigate or affect the response to essential tremor in contrast to Parkinson's disease. So in summary, for essential tremor, this has been just life-altering for many people, because until the surgery, we really had very little to offer patients with really severe essential tremor. Okay, final category to talk about is dystonia. So dystonia is really the most complicated thing to try to describe. Dystonia is involuntary patterned movement. And most people have never heard of dystonia because it's often called different things. For example, dystonia of the neck is usually called torticollis. Dystonia when you write is called writer's cramp. So there's a number of different names that dystonia goes under, but you get this involuntary muscle spasms. when you do, typically when you do a specific action, and it is a pattern. So it should be the same any way you do it, anytime you do it. Now there's a number of different subtypes of dystonia, and this gets a little bit complicated, but the people that respond very, very nicely to deep brain stimulation are these patients with what we call idiopathic dystonias. And this means dystonia not caused by something else like an injury to the head. Patients that have dystonias and often spasticity, where you get just a general muscle tightness secondary to, say, a brain injury or a stroke or a spinal cord injury, those patients, unfortunately, historically have not done nearly as well with deep brain stimulation as those that have it because of some genetic disease, for example. So these idiopathic or genetic dystonias that affect the whole body are the ones that really do sometimes just miraculously well. I mean, some of the most amazing videos you'll ever see are these before and after videos with kids, typically with genetic forms of dystonia. Now, there are a couple of other things that can predict response within dystonia. Similar to tremor, the patients that have more in the arms and legs or distal part of the body are what does better. And patients that have more midline features like the trunk or the neck, that anatomy tends not to do as well. Face, for example, is another area that doesn't do as well, whereas arms and legs are the anatomy that really do improve quite a bit with deep brain stimulation for dystonia. And the other thing is a little bit more difficult to quantify, but patients that have what we consider a kinetic or action-induced dystonia, so that they're really almost normal and then they go to do something like write and then the fingers cramp all over the place, those patients tend to do very well with deep brain stimulation, whereas those that have more of a fixed dystonia, so they're just always in the same position all the time, they tend not to do as well. Now, those patients with the fixed dystonias often are the ones that had head trauma or spinal cord trauma, something like that. So that tends to go hand in hand with the idiopathic genetic. But this is it's a little bit more of a subtle thing that really someone with some expertise in dystonia would need to evaluate. But it's a pretty solid predictor of who does well and who doesn't do well for dystonia. Okay, so with that part, I think I'll hand it over to Dr. Fenoy to talk actually about the procedure itself.
Great. Well, thank you, Dr. Ondo. So I'm going to talk a little bit about the surgery of the deep brain stimulation, and a little bit touch on some of the indications again for certain diseases, and then we'll discuss a little bit of the outcomes that we get to expect and the risks of surgery, of course. So this is just an X-ray of what this whole complete deep brain stimulation system looks like. We see the intracranial leads on this X-ray. I'm going to point to it. Here, these are the leads going into the brain. These are the connectors, the extensions. And then this part goes underneath your skin to a pulse generator that is typically implanted underneath your clavicle. We'll discuss that in a little bit. So, why DBS? Well, as Dr. Ondo mentioned, these are patients in the variety of movement disorder diseases that are FDA approved, as well as new emergent type of treatments. The criteria are expanding, but those patients that are refractory to conventional medication. Deep brain stimulation has been around since 1987. It began in France. It's been FDA approved since 1997 in the United States. And it basically evolved as a way to modulate the brain by intercepting an abnormal brain function activity. In the past, it evolved from a lesion, and there was a specific nuclei in the brain that were abnormally functioning, and there used to be a lesion. Well, instead of causing that type of problem, now we insert a stimulator which provides electricity to override or to somehow regulate the pattern of activity within that nucleus to cause effective motor control. So this is, by placing this stimulator, it is not a lesion, therefore it is reversible. It is not permanent. It can be removed or refined if necessary. But it is advocated because it does provide, as Dr. Ondo mentioned, great relief of motor dysfunction. And to date, there's been about 80,000 cases worldwide. So Let's talk a little bit about this procedure. It typically occurs as two different stages. The first stage is the placement of the intracranial electrodes. This is when we want the patient to be awake, and the patient will be under local anesthetic. They'll be a little sedated, but they will not be under general anesthetic. It starts by placing the stereotactic frame. This is LXL frame that we place around the patient's head in the operating room, and then we go take an MRI. And the MRI it was done with this frame on, so we can localize your brain in three-dimensional space and identify the targets that we're going to want to insert this deep brain stimulating electrode. And this is an example of how we would perform this targeting. We then get our MRI, and I'm going to just point to different things. We look at different coordinates based on the landmarks relative to the frame to identify exactly where in three-dimensional space we want to place this electrode and create a trajectory. So then we bring you back to the operating room, and then we have you sedated, and we fix your head to the frame, and then we will make we'll have shaved your head initially. We will place a linear incision across the top of your head, and then we'll create two holes within your skull and open up the duro, which is the covering over the brain. And then what we need to do while we want you awake, although you'll be somewhat sedated, is that we need to record from those brain structures to identify where exactly we are in three-dimensional space. So by doing that, we insert these very small microelectrodes, and what they do is they record brain activity as they descend through multiple different nuclei along a specific trajectory. This is an example of what we typically may see as we're descending down to the subthalamic nucleus, which is a typical target in Parkinson's disease. So you don't need to know this, but each specific structure has a characteristic signature neurophysiologic activity, which helps us know for sure that we are in the particular target. So the subthalamic nucleus looks a lot different than the substantia nigra, which is much deeper. And we are listening to this activity while we're in the operating room. And so we typically have a few microelectrodes down simultaneously so we can better define the three-dimensional anatomy right there in the operating room. And this is another example of monitoring the microelectrode recordings neurophysiologic activity approaching the globus pallidus internus, which is another very useful target in Parkinson's disease. Again, showing that we are in the right, the target of interest has a very different neurological activity compared to the others, but the point is that we need you awake to make sure that we get a good response to verify that we are in the right structure. Once we have verified we're in the right structure through this microelectrode recording, we will then place the actual deep brain stimulating electrode. So you saw that X-ray earlier, but this is another picture showing the very distal end of the electrode. There are 4 contacts. They're spaced. They're 1.5 millimeters in height, and they're spaced by 1.5 millimeters of plastic. And this will then span that target that we see is adequate. So we'll remove those wires that are recording. We'll insert the actual deep brain stimulating electrode, and then we want you awake because we will then turn it on and we will stimulate. And we stimulate to see not only good effect but also lack of side effect. So if in the case of Parkinson's disease, if you have a resting tremor, we'll stimulate and use a certain parameter setting to see loss of your resting tremor or improvement of rigidity. We will test you, and we'll have either the neurologist or some other research assistants helping underneath the drapes, interacting with you to see very good improvement. We also don't want we have any side effects, and by side effects we mean that as we're stimulating through this electrode, the electricity sphere, the volume of activation, can extend outside of the target of interest to the adjacent structures. And so this is a picture that can better demonstrate that. So say here, this is just a 3D representation of where the subthalamic nucleus is in the brain. It's in the brain stem area. And there are other structures that are around this. And so if we stimulate, we may get a contraction of by stimulating fibers that are a little bit lateral, and we may have some pulling sensation on your hand as you're stimulating, or if you're a little bit, or if you may feel some paresthesias, or which are tingling sensations or numbness in your hand, and that means we're a little bit of activation to some fibers that are just behind that structure. Anyway, the goal is that we want to localize exactly where our target is in the operating room to have good effect without side effect, so that when this is ultimately turned on a month later, that you will want to use this without side effect. So once we're happy with our localization, we then secure the electrodes. This is again a similar slide showing where the globus pallidus internus target is relative in the brain. Here's my little pointer showing again it's just a little bit further out, but again there's structures that we don't want to stimulate to cause those side effects. Once we're happy with that, we secure the electrode. The patient will then be taken out of the frame. The electrode will remain underneath the scalp. Patient will stay overnight typically and then go home the next day. The patient will then return approximately up to 2 weeks later, or whenever it's convenient for the patient, for the second stage of the procedure, where we will then have to place the extension wiring to connect those deep brain stimulating leads to a pulse generator that we typically implant underneath the clavicle. Just kind of, people consider it sort of like a pacemaker because it's in the same location as a pacemaker, but this time it's connected to the intracranial leads. In contrast to the first stage, this procedure is very short. It's typically 30-45 minutes, and you are completely asleep for this, and you will not stay overnight. There's different choices of the pulse generators that can be implanted. I did not mention for the first stage, the typical length of surgery is about 2 to 2.5 hours. Typically, it takes all morning for the whole procedure, including the MRI. So the second stage is relatively quick. You implant the battery, and you go home the same day. There are three different types of pulse generators or batteries, depending on how many electrodes we insert. And there's either a pulse generator that continuously emits stimulation, or one that and then has a finite length of life, and one that is rechargeable and can last longer. And that's something that can be discussed with your neurologist. And here's a typical picture of how the whole system may look. Once it's complete, on these schematics, pulse generator is planted intraclavicularly, and the wire is underneath your skin connecting to the electrodes implanted. Okay, so let's talk a little bit about the utility of deep brain stimulation in Parkinson's disease. Dr. Ondo has already mentioned this, but I'm going to just quickly review this. Again, it's basically for those patients that have symptoms despite best medical management, who don't have dementia or significant cognitive deficits. And those patients that, as Dr. Ondo mentioned, have to have a very good response to levodopa. And this basically will replicate the motor improvement seen with levodopa without having the on-off fluctuations. So those patients that have those dyskinesias, which are those wiggling movements when they're on medication, and then when they're off medication have severe deficits, whether it is slowness or rigidity or tremor, those patients that have these on-off fluctuations that may typically come up to about 6 times a day if they're having their Sinemet or medications that often, these are the patients that can really benefit from deep brain stimulation. So for those patients that really have these continual motor symptoms despite best medical therapy, and for those where there are side effects by increasing the doses of levodopa, and there may be various ones, this deep brain stimulation is an excellent treatment option. And the way this helps is that it really reduces the on-off motor fluctuations that you have by having a sustained improvement in on-time. And over time, after the unit has been turned on, it allows a reduction of the actual dosage of medication, so it also can limit the amount of side effects associated with it. Let's talk a little bit about the outcomes of the surgery. And this is something that many people have looked at, and there are many multi-center studies that have evaluated deep brain stimulation efficacy compared to patients that are receiving the best medical treatment, also comparing the targets of the subthalamic nucleus versus the globus pallidus internus. Also, there have been many studies comparing DBS relative to patients preoperatively. These are just some examples of some very good and often quoted in the literature studies that are multi-center on Parkinson's disease and deep brain stimulation. We can just summarize them, saying that there have been many randomized control studies that found that deep brain stimulation in the correct patient group is found to be more effective in treating the symptoms of Parkinson's disease than best medical therapy. So what they found is that it really, in terms of motor improvement, both the globus pallidus and or subthalamic nucleus targets are somewhat equivocal in the benefit that they can give. And the benefit is typically an extra 4 hours of on time that can be appreciated by the patient without the dyskinesias. Now, that is a real improvement in a patient's quality of life. They also found, summarized, that dyskinesias, which are those wiggling movements, are significantly reduced by 75% compared to preoperative baseline, as well as those receiving medical therapy. Whether it is due to removing the medication so they don't have to take and have those on-off fluctuations, or just by actually the target of choice, that both of those kind of factor into why there's a decrease in dyskinesia. But it is very useful for those patients who don't have control otherwise. We'll talk a little bit on tremor. Dr. Ondo already discussed this, but there's different types of tremor. There's the essential tremor, so-called essential because it's idiopathic without any structural brain problem. It's mostly distal, and it's really troubling for patients that are trying to produce or have some occur some motor tasks, such as eating or writing, or doing anything with their hands. And it's very common, and it gets more common as we age. But patients as young as their teenagers or in their below 10 can still have it. Tremor is also due to trauma, and that is also problematic. And it can be in some subtypes of multiple sclerosis. So for all these patients, of course, the first management would be medicine. But for those patients that have it that is extremely disabling and where medication cannot help it, deep brain stimulation can very much improve their patient's quality of life. Tremor progressively worsens with time, and there's been several studies that showed that at least 50% of patients fail medication. And as Dr. Ondo mentioned, that in the essential tremor population, that failing means that you don't have very good control on medication. It's just not. It may be a little subdued, but it's not. Does not get arrested. So for tremor, deep brain stimulation is indicated for those patients where it is really disabling, and disabling is a very it's personal. Depending on what is disabling to one patient may not be disabling to another. But if you have tremor and it is bothersome and not controlled by medication, then it could be considered disabling. And so those indications, deep brain stimulation is highly useful. This is another schematic of the target of choice for deep brain stimulation. It is the ventral intermediate nucleus of the thalamus. That's VIM, and they show here on this sagittal MRI reconstruction where the thalamus is. It's kind of in the center of the brain, and the ventral intermediate nucleus is part of this thalamus, and it's typically in this parcellation view. It's considered here, and when we place the electrode, it spans this target, and it's very close to other structures that we don't want to stimulate. So again, the procedure is exactly the same for regardless of what target we're choosing, that we stimulate to ensure that we have good effect without side effect. And in the case of tremor, we want to make sure that your tremor is completely abolished in the operating room without any type of side effect. And that's typically what is seen in the operating room, and it's quite dramatic. So outcome, again, we want to discuss whether, how useful is this? Well, this has been around since VIM, ventral intermediate nucleus of the thalamus, deep brain stimulation, has been FDA approved since 1997. Unilateral or bilateral, it can be implanted depending on the patient's needs. It definitely causes significant improvement of upper extremity tremor. Average improvements in various studies are between 70 to 90%. And this has been sustained over years. The fact that deep brain stimulation is modifiable over time is good because typically tremor does change or it does worsen with time. We are not stopping the disease from progression, but we are intercepting its symptoms and or symptoms that are manifested. And so by having the stimulator in place, we can modulate it if necessary. And there's been many studies to show that. So let's talk a little bit about the risks of deep brain stimulation. Of course, every time brain surgery we perform, there's always a risk of bleeding. There's always a risk of infection. So when we open up the skull and we insert anything into the brain, there's always a risk of hemorrhage. This has been seen over many studies have reviewed this in large series. We have actually one of the largest series here in Houston in the world. And it's been seen that about 1 to 4% of patients will develop some type of bleeding worldwide. Very typically, out of those, that's been manifest by or seen on a postoperative image, and most of them are unlikely to be symptomatic. That is the same type of risk for any type of brain surgery, whether it is, and that this falls into the category of brain surgery. Risks of infection. There's always a risk that when we're implanting something foreign into the brain that this can become contaminated, and that can be very disabling. That's a risk of every type of surgery, not only if we are implanting something, but whether we're operating on the brain. Worldwide, it is very low, and there's different studies that have shown that it ranges from 1% up to 18%, depending on the studies in the literature available. In our hands, we have proven that it's about 1% in Houston, and there's a paper in the Journal of Neurosurgery that's coming out this year that details that in our series. There's, of course, since we are implanting this hardware, which is a piece of wire with plastic, it is man-made. It is somewhat flimsy, and these things can break over time, or if they don't break, they can malfunction. And similarly, the pulse generator can malfunction, or it will be depleted, but depletion is not a problem. That's something that we recognize over time. Regardless, any of these, the fact that these are implanted and they can be explanted if it is a problem. They're about 4.3% is the quoted in the literature. 4%, not very high. Again, if one of these things occur, if there's a malfunction or a fracture, we can certainly remove and replace if necessary, which is the whole point about deep brain stimulation. It is not permanent. It is reversible and modifiable. These risks are much lower compared to other cranial neurosurgical procedures, such as brain tumors or aneurysms. It has been around for many years, and it's not experimental. It's something that is proven to be useful. And there's a patient advocate support line by Medtronic, which is the major supplier of these deep brain stimulators. If anyone has questions or patients are interested, there's certainly a patient advocate that can respond. And thank you for listening. We're here to answer questions now.
Okay, so there have been a number of questions, and Dr. Fenoy and I will alternately take these depending on the question. First question is about Tourette's syndrome. Is there actually an FDA approval for, or close to approval for Tourette's? Tourette's is actually one of the more studied things for DBS. The problem in quotations is that there's been at least 7 different locations where the DBS has been implanted for Tourette's syndrome. So there actually has not been a single consensus location, and therefore there really hasn't been the sort of definitive study that's required by the FDA for an approval process. Now, it's still certainly done for Tourette's syndrome, but I'm not aware of any impending FDA approval for that specific indication. Let's see. Do you want to do that?
Sure. So another question is this a bit like a pacemaker in the brain? Do you implant anything or remove any brain tissue? Do you deliver medicine directly to the brain? So as we talked about, this is the pulse generator is connected to the stimulating leads and extension wires. So I guess you could consider it. We really don't know how, but despite all these years, exactly how deep brain stimulation works, but you could say that it's modulating the brain in a certain rhythmical way, delivering high-frequency stimulation, so that we could say that is akin to a pacemaker. We'll discuss what we implanted, and we don't remove any brain tissue. And currently, we don't deliver any medicine directly to the brain.
Okay, there's a question about cervical dystonia. Cervical dystonia, as far as a dystonia anatomy, that's dystonia of the neck, is kind of middle of the road as far as general response to deep brain stimulation. I think it's not quite as good as dystonia in the arms or legs, but it's better general response than dystonia of the face. The standard treatments are botulinum toxin injections. There's actually 4 different types of botulinum toxin and a number of different ways to do this. Medications for cervical dystonia are typically not that effective. So if nothing else is working, and again, if only one person is administered botulinum toxin injections, there's quite a bit of variability on depending who does that. But if really those have been exhausted, it would be a reasonable thing to consider, or at least consider evaluation for a deep brain stimulation.
So what are the risks of deep brain stimulation surgery? This question kind of went over it. The risks of bleeding and infection are about 1%, same as typical for other cranial neurosurgery, which is actually a little less than so. And there's risks of hardware malfunction, of course, and that can be removed and replaced if necessary. Aside from that, we certainly test in the operating room while you're awake to ensure that we don't have any sustained side effects, so that you'll have good use of the electrode.
Just a practical question about medications, presumably in Parkinson's disease. All surgeons, or at least I'll blame it on the anesthesiologist since there's a surgeon next to me, typically want people not to take medicines for 12 hours or so before surgery so they don't vomit during the procedure. But generally, pretty quickly after the surgical process, you can go back on medication.
Right after surgery, you can go back on your meds. Question about what are the cosmetic implications of the surgery. So as I alluded to, we'll be shaving your head, then that's to reduce infection. That's just for the the implantation of the electrodes. There will be, in the way we secure the electrodes, there's a little plastic ring that we put around the burr hole, which will have a little bit of prominence over the scalp. As your hair grows back, it is not noticeable. And again, the wire that goes down from behind your ear to the pulse generator that is underneath your collarbone, it's kind of like a pacemaker, so there is a prominence there, just as it would be in any type of person you've seen as a pacemaker.
There's a question about just preventative treatments in general for neurologic diseases, I take it. Honestly, for any of the diseases we've discussed, dystonia, tremor, Parkinson's disease, there's unfortunately nothing that can, that can legitimately, scientifically is known to prevent the occurrence or the progression of any of these diseases. So almost all the treatments we're talking about are symptomatic treatments.
Yes, the question is this procedure normally covered by insurance? I did not touch on that, and yes, it typically is. That's why we insert these electrodes in those FDA-approved conditions: Parkinson's disease, tremor, and dystonia. They are covered by insurance as well as OCD. And the question is, how long can the leads stay in? The leads can stay in forever, if necessary. Do we ever have to go back in and tweak the placement? Sometimes we may have to, and that's only over years, if necessary. Sometimes they get inserted and they just they're not getting exactly the right therapy that was desired. Beauty of this procedure is that it can be removed and replaced or revised if necessary. The goal is not to have to do that, but certainly possible.
There's a couple of sort of questions about sort of management of, I think, predominantly Parkinson's disease in general. This one about freezing spells. Well, some of you mean freezing gait where the foot's just stuck to the ground. That's a major problem in Parkinson's. There's nothing better to treat it than the typical Parkinson medicines like levodopa. This is actually one of the things that we evaluate very carefully when we're assessing people for deep brain stimulation. If the freezing of gait improves with even sometimes very high doses of levodopa, it typically will improve with deep brain stimulation. There are patients, though, where the freezing of gait doesn't improve at all with any amount of medication, and they, as a rule of thumb, don't do as well with the deep brain stimulation. So that is a very specific scenario that we look for when we're evaluating patients for this condition.
Sure. Question, practically during the procedure, so yes, you will turn that on. We want you awake because we want you to experience, or we want to see what is occurring when we have these stimulators turned on. So we'll usually have your hand held outright, and we'll see if you're having tremor. We'll arrest the tremor, and we will be asking you, do you feel pain? Do you have numbness? Do you feel contractions? And you'll be telling us if you do. And so that'll give us an idea about where the electrode is. Sometimes feeling a good numbness is the perfect shadow of where of indication that we're in the right location. So it's not painful, though. This procedure is, although it is awake and sounds very scary, possibly, it is not painful.
And ironically, the brain is the only part of the body that really doesn't feel pain at all. So you can take an ice pick, mash it around, whatever, you're not going to feel a thing from that.
Where's it? Oh. Sure. The question of the DBS, risk of DBS, there's always a risk of death with deep brain stimulation, just like with any brain surgery, and I don't have any. It's very extremely low and very uncommon.
Yeah, I would agree. In about 16, 17 years of being part of this, I've never seen anyone die around the time of around the operation. There's some questions about the adjustments afterwards, because after it's implanted, that's the only part of the story. The number of things of electrical parameters can be adjusted. This varies tremendously. I mean, there are some people that we adjust once or twice, and then we don't see them again for 2 or 3 years because they're doing great, and other people that we see on a much more regular basis to make little tweaks. So I can't say there's any set pattern of adjustments. It just depends on how patients are doing afterwards. And these adjustments, of course, are done in outpatient, typically by the neurologist. That depends on where you get it, but in most cases in our system, the neurologist would do this. And they often take about an hour or so to do these adjustments. I think just another question about, botulinum toxin injections. For cervical dystonia, if that's what the question refers to, I think most people would consider botulinum toxin injections to be the first line therapy simply because it's, it's much less invasive, it's much easier to do, and if the control is adequate, then, I would recommend staying with that. If it is inadequate for whatever reason, then deep brain stimulation can certainly be explored.
Right, and Medicare is one of the definite insurances that would cover this. It would be depending on exactly what you have, but very likely. Yes, the question is, do VA hospitals perform the surgery? There are. Most VA hospitals, if there is a functional neurosurgeon there and a neurologist that is willing to program the patients, a lot of VA hospitals do perform the surgery. It just depends on which one and what area.
All right. Well, there's a question about the duration of therapy, and this is a good question. There's what improves with the DBS, as a rule of thumb, continues to improve for as long as we've been doing this. The problem is that the disease can change, and for example, in Parkinson's disease especially, you may still have fantastic control of the motor symptoms, the tremor and so forth, but 10 years down the road, patients now have dementia or other symptoms that don't respond to this. So the effects of DBS, as a rule of thumb, are persistent, but again, there can be change in the overall effect on the patient because the disease continues, unfortunately, to progress, and other symptoms may become more of a problem. And in any individual person, specific problems with medications and so forth that might be used in surgery, that's going to have to be discussed with the physician. But there's usually a number of different options for anesthesia, et cetera.
Right, and in terms of if you had a DVT and you've had some anticoagulants, we would have to discuss with you and your treating physician how long you've been on them and if it's necessary. But certainly around the time of surgery, you need to be off of anticoagulants.
Okay, well, I would say most major medical centers have people that are pretty well versed in deep brain stimulation, both from neurosurgeons and neurologists. In Houston, certainly at Memorial Hermann, Dr. Fenoy is the person that does most of these surgeries, but also at Baylor College of Medicine, Methodist Neuroscience, there are people that do these in the Houston area. Medtronic Corporation and their websites would actually be another resource, which is maybe still be on here. This number or their web page is another resource to actually find physicians that have a fair amount of experience with deep brain stimulation. Okay, that looks like essentially all the questions, or at least we've tried to paraphrase responses to a couple that we didn't answer directly. I would like to thank everyone for attending, and good luck with your future decisions.
Yeah, thank you so much for listening, and if there's any questions, you certainly can contact both Dr. Ondo and myself, and we'd be happy to talk with you further about this. Thank you for your attention.
Good afternoon.